into three sections. One is the inter-organ crosstalk and how it causes the beta cell failure. And then we have the multi-organ crosstalk and the insulin resistance. And then how pharmacological approach or the new agents can be used to address this organ crosstalk. So organ crosstalk represents a system of biological communication that makes it possible for cells in one tissue to send information to cells in another tissue even at relatively long distances. So one organ is communicating with a different organ and they're not related to each other. This process involves molecular, cellular, neural factors, and it's a very key determinant of physiological homeostasis with a deep impact on hormonal signaling and action. A complex scenario of crosstalk mediators involving nutrients and metabolites, extracellular vesicles or exosomes, peptides and proteins that may be collectively called as organokines. So furthermore, multiple organs participate in this crosstalk communication, including the adipose tissue, skeletal muscles, the liver, brain, gut, and to extend that, even the macrophages, bone, the endothelium, all these organs, are involved in the crosstalk. And these crosstalk mediators are becoming increasingly important, because their action as modulators and as blood biomarkers in disease progression. And type 2 diabetes mellitus, as we know, is a complex multifactorial disorder characterized by both insulin resistance as well as pancreatic beta cell function defect. As the disease progresses, the chronically increased workload on remaining beta cells results in their failure, ultimately leading to hypoglycemia. However, in the diabetic milieu, chronic excess of nutrients such as glucose, free fatty acids, and lipid intermediates synergistically induces deleterious effects on both beta cell mass and also the function, and creates a vicious cycle that contributes to progressive loss of beta cell mass. To sum up, this is the glucolipotoxicity. And concomitant effects of inter-organ crosstalk associated with beta cells and how insulin resistance negatively impacts both the function and mass of the beta cells. So if you look at the slide here, it looks a very busy slide, a little bit confusing, so many arrows are there. But to sum up, there are different mediators or different hormones or different signals working here. If you look at the center, we have the pancreatic beta cell, and there are two adipose tissues, you can see in the slide. One is the obese adipose tissue, and the other one is the lean adipose tissue. Coming to the obese adipose tissue, it secretes leptin. Leptin, as you know, has a deleterious effect on the pancreatic beta cell, but at the level of the brain, it decides how much you eat, whether you eat more or less. And this leptin also has an effect on the osteocalcin, which is produced from the bone. And in turn, this osteocalcin has, its effect on the beta cells. That is, it is an insulin secretagogue. And making it more interesting, insulin secretion itself, controls the osteocalcin. So in diabetic patients, many times we see the bone cycle actually changes. In the same way, the lean adipose tissue, the good adipose tissue, has adiponectin, which has a positive effect on the pancreatic beta cell. We also have the inflammatory markers like the IL-6. Actually, IL-6 is deleterious for the beta cell function. But when one exercises, the IL-6 increases, and this increased IL-6 through the L cells of the intestine actually decides how the GLP-1 secretion works, whether it increases or decreases. So it's kind of a two-way action, you can see. We also have something called kisspeptins hormone, which is actually mediated by the pituitary gland, and it's altered by estrogen. But now we know it's also secreted by the liver, and it's influenced by glucagon. So glucagon is influencing kisspeptin. This kisspeptin having a negative effect as far as pancreatic beta cell is concerned. At the level of the muscles, skeletal muscles, and also the peripheral tissues, free fatty acids, uptake is also being affected. So all these things it looks very simplified, but actually it's very complex. Either it is one mediator predominating the other, or both of them working together, or sometimes it is all or none. So definitely a very complex signaling or communication is going on between all these organs. So this is a very comprehensive slide. I think when the ominous octet was postulated by DiFronzo, I think DiFronzo underestimated the organ crosstalk which was occurring, because apart from the ominous octet, we have the tissues like the cardiac muscle, the bone, the sex hormone estrogen, the gut microbiota, the thyroid hormones, even the immune system. So all these things working together in a complex way, and bringing about the progression of metabolic disease. So lipotoxicity is a type of cellular stress which is induced by accumulation of lipid intermediates such as diacylglycerols, ceramides, and triglycerides. Lipotoxicity facilitates the development of insulin resistance at the level of the muscle, liver, and the adipose tissue, and metabolic inflexibility is characterized by impaired fluid switching and energy dysregulation. These concepts are both closely associated with insulin resistance and cardiometabolic disease. In obesity and insulin resistance, the skeletal muscle capillary network is compromised, impairing the insulin-mediated capillary recruitment. So we have both the canonical insulin target tissues and the non-canonical insulin target tissues. Canonical target tissues include the adipose tissue, the liver, and the skeletal muscle, while non-canonical target tissues include the beta cells, brain, and the bone. So as I mentioned earlier, these different organs are working in tandem in a very complex way and bringing about the insulin resistance. At the level of the liver, there is increased hepatic glucose production, decreased insulin mediated glucose uptake at the skeletal muscles. Centrally, the brain, there is decreased neural function, increased satiety, impaired leptin signaling. And at the level of the bone, increased bone loss due to osteoclastogenesis, and there is ongoing inflammation. As you can see in the center, there is increased free fatty acid production. The macrophages are activated, leading to a systemic insulin resistance, and the end result is the increased beta cell apoptosis and decreased insulin secretion. So the same thing has been elucidated here in this slide. Liver, if you see the biochemical changes, increased free fatty uptake, steatosis, inflammation, Kupffer cell recruitment, increased cytokine production, ER stress, and insulin resistance. Same thing is happening at the level of the adipose tissue. There is increased free fatty accumulation, adipocyte hypertrophy, macrophage polarity switch, increased cytokine production, increased lipolysis, ER stress, and insulin resistance. Skeletal muscle, the same thing is happening. Now at the level of the pancreas, there is macrophage infiltration, increased cytokine insult, inhibition of the insulin signaling, ER stress, beta cell hyperplasia, impaired insulin secretion, finally beta cell apoptosis. So the brain also is making different signals centrally, contributing to this metabolic derangement. And there is also this kidney-heart connection of organ protection. Apart from the fatty liver, now we have the fatty kidney, fatty heart, and the fatty pancreas. At the level of the kidney, when there is natriuresis, diuresis, and restoration of tubuloglomerular feedback, there is decreased glomerular hypertension, increased distal delivery of sodium, decreased tubular workload. It has positive effect on the heart. There is decreased left ventricular wall stress, oxygen delivery increases, there is decrease in oxidative stress. That leads to decreased blood pressure, increased red cell mass, increased ketones, decreased insulin resistance, increased glucagon. Finally, we have decreased plasma volume, decreased sympathetic nervous system activity, increased erythropoietin activity, and normoglycemia, and there is also decreased body weight. So how we should approach this organ crosstalk in a pharmacological point of view? The endocrine pancreas is a key factor in regulating glucose homeostasis. Incretin-based therapies, they ameliorate beta cell dysfunction and potentially delay the requirement of exogenous insulin. Metformin reduces the free fatty acid efflux from the fat cells, thereby suppressing hepatic glucose production, indirectly improves peripheral insulin sensitivity and endothelial function. Thiazolidinones like pioglitazone, they improve peripheral insulin sensitivity by reducing circulating free fatty acids, and also by suppressing adipocytokines which release insulin resistance. Both SGLT2 inhibitors and GLP-1 receptor agonists, they have effects on multiple organs in the body, modulating not only glycemic control but also lipogenesis, satiety, smooth muscle tone, and the EGFR. Agents, if you look at the agents that increase or preserve beta cell, we have the GLP-1, GIP, DP4 inhibitors. All these are incretin-based therapies. Insulin, epidermal growth factors or gastrin, thiazolidinones, growth hormone, hepatocyte growth factor, human placental lactogen, insulin-like growth factors, parathyroid hormone-related peptide, prolactin, keratinocyte growth factor, beta-celuline. These are some of the beta cell proliferators or neogenesis of beta cells. So the same thing here, how the metformin and thiazolidone bring about the effects or address the crosstalk between liver, the adipose tissue, muscle, and the pancreas. This slide is very interesting because we have the physiological mechanisms of novel pharmacological agents like SGLT2 inhibitors and GLP-1 receptors, affecting different organs in different ways, bringing about not only euglycemia, but also weight loss, cardioprotection, and also nephroprotection. The SGLT2 inhibitors, they have no CNS activity, that's sympathetic nervous system activation, but GLP-1 receptor agonists definitely increase the sympathetic nervous system activation. And at the level of the kidneys, if you come from the bottom, at the level of the kidneys, there is decreased tubuloglomerular feedback, vasoconstriction of efferent arteriole decreases, there is decreased intraglomerular hypertension, decreased hyperfiltration, decreased blood pressure, and decreased afterload. Then that has a positive effect on the heart. There is increased glycosuria, natriuresis, so the plasma volume decreases, the preload decreases, the stretch on the myocardium decreases, and ventricular arrhythmias also decrease. And then the weight loss, because of the glycosuria, there is weight loss, and there is adipocyte glucose uptake increase. So there is euglycemia. Apart from that, we have the pleiotropic benefits of weight loss, cardioprotection, and nephroprotection, because these agents are addressing the crosstalk. Same way as GLP-1 receptor agonists, apart from the central signaling causing increased satiety, decreased food intake, neuroproduction, they also have decreased gastric emptying and decreased intestinal motility. So these newer pharmacological agents, SGLT2 inhibitors and GLP-1 receptor agonists, are addressing majority of the Argon crosstalk. The same thing has been elucidated in this slide also, the effect of SGLT2 inhibitors and GLP-1 receptor agonists positively on different organs, interrupting the Argon crosstalk. So to conclude, progressive loss of functional beta cell mass is central to the development and progression of type 2 diabetes, and inter-organ regulation may play a causative role in the development of type 2 diabetes by modulating the processes that render the beta cells unable to respond to increased metabolic demand. And insulin signaling machinery is a highly complex network of organ communication, and it plays a key role in regulating the metabolic homeostasis, and evidences of better understanding of the Argon crosstalk would provide clues to enhance beta cell function or to enhance the beta cell mass in the long-term goal of treating or curing the patients with diabetes. I would also like to mention a line about exosomes and also miRNAs, that is a microRNAs. So the microRNAs are very short, non-translatable information which can be inherited, and apart from the hormones, microRNAs are also a very special modes of this Argon crosstalk. Similarly, we have the exosomes, which are pockets of information which are moving from one organ to another. So definitely, if you look at the specialists in terms of Argon crosstalk, I think exosomes and microRNAs need a mention here. So I conclude my presentation. Thank you for your kind hearing.
Thank you, Dr. Yousuf, for the nice talk. You have enlightened us for, I think he's available online.